We will continue our lesson with asthma. When we say asthma, is also a condition of the respiratory tract. As COPD is irreversible, asthma is a reversible condition of the airway that causes hyper-responsiveness, mucosal edema, and excess mucus production. Asthma is largely reversible, as I said earlier, unlike COPD, that is fully irreversible. And asthma normally occurs at any age, but the most common disease of childhood. Asthma is caused by a combination of factors, which one is genetic and also environmental factors as well. Intrinsic factors or extrinsic factors. When we say intrinsic, they are allergies that are not obviously seen, and extrinsic factors are those that are seen as external allergies or seen in the environment. The most strongest predisposing factor of asthma is allergy. When one gets exposed to irritants or allergies, it increases your risk of developing asthma. And allergies can come in the form of spray, mold, animal dander, gas, grasses, trees, perfumes, creams, in any form, soaps. Any form of allergies can trigger an asthmatic attack. Also, when there is extreme emotional disorders, or when one is emotionally upset or stressed up, it can lead to asthma. Also, when one is triggered by over-exercising and you have the risk factor for getting asthma, it can increase your risk. Also, upper respiratory tract infections, example is sinusitis, acute bronchitis, bronchiectasis, pneumonia, silicosis, and other conditions can trigger one to get asthma. Certain medications, example is non-steroidal anti-inflammatory drugs, aspirin, and others can cause or trigger or increase one's risk of getting asthma. In asthma, there is inflammation of the airway, and it occurs because there is mast cell release which causes changes in the airway. Chemicals that are released include bradykinin, prostaglandins, leukotrienes, and others. And when these chemicals are released, they cause inflammatory response, increasing blood flow to the airway and then causing bronchospasms or spasms of the bronchus, which leads to bronchoconstriction or vasoconstriction. So the vessels becomes constricted and more white blood cells are attracted to the area, and this will further lead to mucosal edema. The mucous lining of the airway becomes edematous or swells up, which will limit or decrease the airway. And then bronchospasm also causes further narrowing of the airway. And then when there is increased mucus production, the airway further becomes smaller. So it will lead to difficulty for air to pass through the airway. And this is what will bring about the symptoms in asthma. When there is increased mucus edema and constriction of the bronchus, it leads to sudden dyspnea or sudden difficulty in breathing. Also, there will be wheezing. When air is passing through the bronchus, it will make a wheezing sound because the airway is constricted or has become very small for air to pass through with ease. So it will make the wheezing sound. Then there will be cough because there is increased mucus production. So the patient will try to cough out thick mucus or thick sputum, or will try to bring out this thick sputum so that he can be able to breathe well. There is tachypnea, and patients try to use accessory muscles for breathing. There will be increased pulse. There will be profuse sweating because you will try to use more energy to breathe, and then fatigue or tiredness. In diagnosing asthma, we can do pulmonary function tests, which will reveal an obstructive airway disease. Arterial blood gases, just like in COPD, can be done, same as chest X-ray, to see or to show lung hyperinflation, and also to look out for local athleticis or local lung damages. Skin testing for allergies can be done so that we will be able to determine the specific allergies that is causing the asthma. And also we can treat asthma with salbutamol or bronchodilators. And we can also give oral sympathomimetics, corticosteroids, and mast cell stabilizers can also be given to treat asthma. Status asthmaticus is a severer form of asthma which does not respond to conventional therapy like normal asthma. In status asthmaticus, when there is vasoconstriction which leads to mucosal edema, excessive mucus production, the bronchospasms, and the LOTS, the patients do not respond to bronchodilators or conventional therapy that is used to manage asthma. So it becomes severe and life-threatening. This attack can last longer than 24 hours. Unlike a simple asthma that is easily reversible, status asthmaticus becomes severe and more persistent. Infections, anxiety, nebulizing, abuse, dehydration, and etc. can lead to status asthmaticus. Clinical manifestations of status asthmaticus includes that of asthma, that is wheezing, coughing, difficulty breathing, rapid pulse, and the others, but can be more exaggerated and more severe in status asthmaticus, and patients can get more labored breathing, prolonged exhalation, engorged neck veins, and other symptoms. Status asthmaticus is a serious emergency and should be considered as such. So when patients come with status asthmaticus, oxygen supplementation should be started immediately, and IV fluids should be given for hydration to help to lighten the secretions as well. Patients should be constantly monitored on the cardiac monitor so that the vital signs, including the SpO2, heart rate, respiratory rate, blood pressure, and the others, can be monitored continuously until the asthmaticus is controlled. If necessary, patients should be managed in the intensive care unit when the need arises. Assess the patient's skin turgor to identify signs of dehydration and give at least minimum of 3 to 4 liters of IV fluids unless it's contraindicated in the patients. Nurse these patients in quiet room, avoid tobacco smoking, perfumes, and other odors that triggers the attack. Continuously reassure patients with status asthmaticus and place them in the semi-fowlers or upright position. Encourage them by teaching them the pursed lip and the diaphragmatic breathing, which can help them to relax. And also, always remember to loosen their tight dress or clothing around the neck, which can cause further discomfort. Administer IV fluids as prescribed. Observe the respiratory pattern and then monitor them on the cardiac monitor. Nurse them by teaching them to avoid things that trigger the attacks. Avoid NSAIDs or aspirin that can further trigger the attack. And then counsel these patients and their relatives to be able to give support to their patients. This is all on asthma. We shall continue another time.